Our next speaker is Dr. Sushil Agarwal, and he will be talking about the role of pulmonologist in palliation of lung cancer. Dr. Sushil Agarwal is a senior consultant pulmonologist currently working in Apollo, Kolkata. He has been trained in UK and was working as a consultant in Glenfield Hospital, University of Leicester, NHS Trust UK. Dr. Agarwal has got keen interest in thoracic oncology and thoracic intervention. Over to Dr. Agarwal.
Thanks, Animesh. Can you hear me?
Yes, we
Hello?
can.
Yeah,
Yes.
Thanks, Animesh, for a kind introduction and inviting me for the talk here. Let me share my slides. I don't know whether, I think when you gave me this topic of role of pulmonologist in palliation of lung cancer, it came to my mind that palliation starts even at the time of diagnosis and sometime before that, before we know that we are dealing with the lung cancer. And with the different structure in different parts of the world, palliative care consultants are not always available, though we rely a lot on them. But palliative care in lung cancer starts, and I think is everybody's responsibility. So I kept my talk mainly towards endobronchial interventions, pleural intervention, and some other common issues which we come across in the patients of lung cancer. So as I said, sometimes we even don't know whether we are dealing with lung cancer because almost 1/3 of our cases come through emergency and with acute presentation. And unfortunately, they have poorer performance status and they do worse. Their associated comorbidities and other conditions make them difficult to treat in the terms of curative treatment. So we need a both plan of a diagnostic strategy as well as treatment plan in that cases. So just to, this is very common for all of us. Men in 60s comes with a Haemoptysis, streak of blood, not getting better with the course of antibiotics, on and off cough for few months or few years, and has a strong smoking history. And when you do an X-ray for this patient, you find an abnormality. You can see right hilar abnormality with atelectasis at left hilar abnormality with atelectasis at left upper lobe, which we can confirm on CT scan. And here we can see that it's not only the mass at the hilum, but it's endobronchial growth in the trachea, and is compromising the tracheal lumen quite significantly. And these are the cases where you need to intervene soon because you are at risk of losing the airways, and it's one of the major airways which are at a risk, which we can see on the parenchymal window as well. So then it comes to our main discussion, which endobronchial intervention, particularly in the background of endobronchial obstruction. And with any large airway involvement, these patients need to be monitored very closely, both in their clinical, with their clinical symptoms as well as their radiological appearance, and need to be offered treatment pretty soon. Endobronchial intervention with or without stenting and can be done. And some of the cases they do respond. I'm talking in front of mainly oncologists, but I think they do respond to radiotherapy. But before that, sometimes we do not know even the histology for these patients. When we deal with these patients, there should be a distal lumen where it can open to. So, for example, if you are dealing with the obstruction of the right upper lobe, if there's a complete atelectasis and there is nothing to go into, there's no point in debulking or trying to salvage that airway. So also that all cancer service should have access for intervention and endobronchial treatment in these cases. So what we can do for these cases, we can do debulking by various means, by laser, electrocautery, stenting, which has a more immediate effect. And sometimes these are not very commonly done because of probably the delayed effect and not easy availability, but brachytherapy and photodynamic therapy can be considered in these cases along with the cryoablation. So when we talk about how to deal with these endobronchial tumors or endobronchial obstruction, we deal with hot techniques or cold techniques. The common ones are electrocautery, argon plasma coagulation, and laser treatment. So with the electrocautery, which is more easily available and cheaper, you can do the pass the heat waves with the electricity, and can cause tissue destruction, and along with the destruction of tissue, opening the lumen, it can achieve a good hemostasis. But we have to be careful with the depth of penetration. Not that difficult to train, but cannot be done in patient with pacemaker or extraluminal lesions. And similar way, APC, which is also quite commonly available, can be used by passing ionized argon gas, and it can achieve a good hemostasis and can open the airways. But the availability and the expertise can be sometimes a limiting factor. Laser is much more expensive, but has better results in most of these cases. And it can you can apply the laser waves parallel to the bronchial axis, and these can cause destruction of the tumor and open the lumen. In all these cases, we have to be careful because the risk of fire, and with any of these, and anyone with a high oxygen requirement, we might not be able to offer this kind of treatment. But with the cold techniques, we can use carbon dioxide or nitrous oxide to cause freezing of the tumor, and this can be removed. However, there can be risk of bleeding in these cases, and as with the hot techniques, the risk of bleeding is higher with the cold techniques. And when we open the airways, the next thing is we need to keep it patent, and we have to think of stent, whether we can put a stent, which stent, and whether to put it or not to put it. There are various kinds of stent available in the market, but in the oncological setup, we end up using either a silicone stent or a covered metal stent more often than other. And when we look at the stent, we try to find something which is ideally should be cheap, easy to place, easy to remove, with no or few complications, and suitable for most indications. And it should be adaptable as well, but unfortunately, one size doesn't fit all. And all the various stent available have their pros and cons. And we can see that though silicone stents, which are human stents, are cheaper, but they are not very easy to place. They need general anesthetics as well as rigid bronchoscopy as compared to flexible bronchoscopy, which is commonly done in the bronchoscopy suite. And we can put a metal stent with a covered metal stent in these cases. The complications are very similar for both the cases. And when we look at what can be in what we hold in the future, we might be using different kind of stent which can be individualized by 3D printing for the individual airways, by drug-eluting stent, or even iridium particle studded stents. This is not uncommon. We see patients coming through our emergency with massive pleural effusion, and this is another scenario where we sometimes we do not know the diagnosis, sometimes we do, and interventions as well as palliation both comes into play, and you have to do together sometime. What we can do for this kind of cases are whether we can do a therapeutic aspiration or put a chest drain with a view of doing a pleurodesis afterwards. But sometimes we do not have a histological diagnosis. Next slide, please. In cases of recurrent pleural effusion, we can insert an indwelling pleural catheter where we can keep the patient out of the hospital. But technicality and availability and cost becomes an issue. And not many centers have the follow-up services for indwelling pleural catheter. The patient's treatment at home can be a challenge. You can train the district nurses or or the family members or patient themselves to drain the pleural effusion, and that's the aim to keep them out of hospital. When we do not have a diagnosis, or even sometimes when we do have a diagnosis, in case of massive pleural effusion, we can go by doing a thoracoscopy and putting a talc by Podras. And whether you can do a rigid thoracoscopy or a semi-rigid thoracoscopy, the results are pretty much similar. You can take the biopsy, which can provide you adequate sample for molecular analysis. And along with that, you can do the talc Podras, which is a much better outcome than talc slurry. Now, we know that with the immunotherapy and more of targeted treatment, we are using more and more more of these agents, and these do not come without any complication. They have their own downside, though fortunately the downsides are very limited as compared to the benefits offered by this treatment. In this case, it's a 66-year-old man with non-small cell cancer on pembrolizumab for PD-L1 positive tumor. Presentation is 3 weeks history of cough, fever, and malaise, shortness of breath, and hypoxia. And when we look at the X-rays and radiology, next slide, please, we can see a clear change in their lung parenchyma, and we can see that these patients do get side effects from immunotherapy by developing this pneumonitis. And these are commonly used drugs nowadays, not only in lung cancer, but in other cancer as well. And fortunately, the incidence of side effects are pretty limited, in less than 10% in most of the cases. And depending on the severity of the underlying problem, you can either delay the treatment, withhold the treatment, or sometimes you have to discontinue treatment. The important point comes with differentiating it from underlying infection, particularly opportunistic infection. And we might or might not be able to do bronchoscopy, because sometimes patients are too hypoxic to do a bronchoscopy. If they are on intubation, then it gets easier, but otherwise you have to rely on the sputum sample. And but important point is to make sure that there is no underlying infection. This niche treatment, sometimes with the stopping or delaying the treatment with the immunotherapy and use of steroids along with it. If they do not improve, you might have to consider infliximab or MMF in these cases. This is not uncommon. We do see Haemoptysis coming through our clinics through emergency door, and one of the biggest challenges is whether to admit these patients or not, whether this is really Haemoptysis or not, and whether it is coming from the upper airways, whether it is severe or not severe, whether it's massive or not massive. When we talk about massive Haemoptysis, there's no clear definition to it. I think any patient who's at risk of compromising their airways or hemodynamic compromise, we call it massive. We do a CT scan, CT angiogram, and look for any possible embolization of the bronchial arteries. Bronchoscopies, I would say flexible bronchoscopies, I think I'm not a big fan of flexible bronchoscopy in massive Haemoptysis, because the lumen of the bronchoscopic channel is very, very small, and you cannot remove all the blood. The vision is poor unless the patient is on ventilator. A rigid bronchoscopy gives a better lumen and control of the airways, and might offer treatment of underlying tumor or bleed from it. And but whenever we see these kind of cases, we know that the prognosis is probably not good, because there might be erosion of a major artery. Supportive treatment we always have to continue along with, by transfusion, by tranexamic acid, and with or without use of opiates. Sometimes we do come across this puzzling situation of use of moderate to severe cough, presentation of moderate to severe cough, and despite using antitussive and all the supportive treatment, this can be very, very difficult to control. We can use opiate, we can use pregabalin, gabapentin, and other medications, but sometimes you have to take a step back. You have to think whether change of underlying treatment of cancer itself might be needed in these cases. Thank you. I'll stop it here. Thanks for. I'm happy to take any question here.
Thank you, sir, for a nice presentation.